All right. We are up and running.
All right.
All right. So thank you all for being here. We're really excited to bring in a wonderful speaker to speak on the topic of the North Carolina Medical Board, kind of what it is, how to use it, how to, the different things that you can do, when working with them. So a little bit about Dr. Karen Burke-Haynes. She is a MD board certified in pediatrics. She has practiced primary care pediatrics in North Carolina since 1993 and was the owner of a small pediatric practice in Raleigh before joining the North Carolina Medical Board in 2014 as Associate Medical Director. Dr. Burke-Haynes accepted the role of Chief Medical Officer in 2017. As Chief Medical Officer, she is responsible for overall management of the Office of Medical Director and assisting the board staff and the board in investigating and reviewing matters that may involve quality of care concerns by serving as a subject matter expert and making recommendations to the board regarding those matters. She is a graduate of Trinity College in Hartford, Connecticut, and the University of Rochester School of Medicine and Dentistry. She began her career in medicine caring for indigent and homeless pediatric populations in New York City, utilizing mobile medical units. Dr. Burke-Haynes also serves as a resource for licensees, public organizations, governmental agencies, and other individuals and organizations that contract with the board with requests for information. So thank you so much for being here and
Thank you,
speaking with
Corey.
us. Yeah, and I'm really looking forward to, and hopefully our viewers are looking forward to just hearing a little bit about the North Carolina Medical Board. So all
Thank
yours.
you. Thank you. Thank you, Corey. Thank you for your very kind introduction. Thank you for the opportunity to speak, to share about the North Carolina Medical Board and the work that we do here, and to have the opportunity to introduce your community to a resource that I think has a place in everyone's household. As long as you're dealing with health, I think it's a good thing. It's a good thing to know about your board and why it's here and how it can serve you. So I'll jump right in and start giving you some basic background information. So the North Carolina Medical Board, I'm going to touch on 4 basic areas according to our agenda, and we'll first touch on the idea of its mission and its responsibilities. So your North Carolina Medical Board is an agency. It is a state agency. However, it's not considered to be a part of state government. It interacts with and licenses doctors, and that would be MDs, doctors of medicine, or osteopaths, DOs, doctors of osteopathic medicine, and physician assistants. There are other minor groups that we cover, but for the sake of this presentation, we'll focus on our doctors and PAs. The responsibility of the medical board is to enforce the laws and rules and precedents governing the practice of medicine. So a clinician might attend medical school, residencies, become certified. They now know how to practice, but it's important to have a defined boundaries on how to deliver care in order to keep that care safe for the community and also to protect the reputation of the practice of medicine. It is a self-funded entity, and that simply means that it is not funded through government sources, but indeed is funded by the clinicians of the state of North Carolina, the licensees of the state, the licensees of the board. We have a fairly modest staff that is housed mostly and primarily in Raleigh, with other elements of our staff scattered throughout the state, in that that serves the purpose of being able to allow the board to have a glimpse and to serve the communities throughout the state, as opposed to just a concentrated area here in the Triangle and Triad. We have 13 board members that do come from across the state. This is the current board that is actually winding down at the end of this month. Many of the faces that you see here are individuals who will continue on, and in November, some will, the end of October, a handful will be rotating off, a new set coming in, and the continuity goes from there. It represents a very diverse, it certainly doesn't reflect all, but it is a much more diverse collection of individuals than you might have seen in the earlier years of the formation of the board. So the board was established in 1859 under the auspices of the General Assembly. And I mentioned to you that purpose, and so in our specific language, I think it's important to state that it was created in order to properly regulate the practice of medicine and surgery for the benefit and protection of the people of North Carolina. Historically, in the field of regulation, prior to the establishment, the rooted establishment of medical boards, not only in our state, but across the nation, medicine was a wide open field with no way to really verify if someone called themselves a physician or a PA, excuse me, not PA, but a physician or a practitioner of medicine. There was simply no way to really know that and vet that. So of course, there was a need for change, and that change began in 1859 in earnest. We'll go over the duties now for the main duties of the board. So how does the board achieve its work? Well, it fulfills its mission through a gatekeeping function, which is essentially licensure. Licensure simply means I'm a clinician training in any part of the world, actually, but in, let's say, the United States. I have an interest in coming to North Carolina. It is a responsibility to gather as much information, factual data as possible, to vet and confirm that that person is who they say they are, that they've trained in appropriate programs, and that they are truly eligible to come to the state and practice medicine in a safe way. So that's the beginning and the root and the foundation of regulation. Who are we letting into the state around in the setting of practicing medicine? Regulation of the practice includes matters of what we call remediation and discipline of licensees. So if there's a problem, there are things going on, we have the ability by law and statute to insist that a physician who may not be practicing to standard, or a PA, seek a form of remediation, and in some situations, depending on the nature of what's going on, discipline. And we are also active in the area of policy development. The licensees, as of January 1st of 2021, the distribution, this pie chart gives you a sense of the number of the distribution of physicians versus osteopathic, so MDs, DOs, those who are physician assistants, and then our minor groupings that I've mentioned there are residents, those are doctors in training, licensed perfusionists, and anesthesiology assistants. This is a heat map of the state of North Carolina that helps us to understand the distribution. So though we are rich in clinicians, the heat map clearly identifies that the distribution is not as strong as you would like. We have heavy distributions in the larger counties. It starts to fade out, but you actually have counties that may have 0 to 10 clinicians to cover the care in that area. Heading out in the border states, on the margins here, It's an unfortunate situation, I think, for those receiving care in those communities. So distribution is a challenge. There's no easy way to address that, but just pointing that out in case you're listening from a community and you're wondering, hey, where are these folks? It is recognized as a challenge around how clinicians are distributed in the state. Some fast facts that might be of interest to the audience pertains to the number of licensees that we generate per year, the percentage of those that are represented by physicians, the residents. Those are, the state has 1,000 to 100, 1,100 doctors in training, so to speak, but that changes. Not everyone stays, but we are a major training center here in North Carolina. And we also have the capacity to do things, i.e. issue emergency licenses in times of crisis. So certainly the pandemic afforded some opportunities for emergency licensure, and the board was able to respond and react to that need. Now, the complaints and investigation process, the regulation process for our organization. So we have the terminology that we use for the evaluation of care that comes or is brought to the board's attention by people in the community. The terminology for that is enforcement. So we have enforcement cases that take on the shape of complaints, which would be submitted primarily online occasionally, and also there's an option to submit by paper. So that's a matter of someone in the community saying, hey, I had an interaction in a clinician's office today where I felt either professionally things did not go well, there was something grossly inappropriate about the interaction, or there is a lingering concern I have about the care that was provided. The community has the opportunity to go to the board's website and offer that information, clarifying the events and helping us to determine how we can respond, or giving us information that we need in order to respond to that, reaching out to that licensee, interacting with them and getting information so that there is a balanced reporting of the events. There are some situations that require actual field investigations where, in order to get a clarity, for instance, a typical, an example would be someone who's had an interaction in an office, but the office there was a concern that perhaps equipment wasn't clean. Someone used a used instrument for a procedure, that sort of thing. Then there is a need then to not only have the narrative shared with us, but to send an investigator out to do some on-site checking, looking, and talking with people. We manage about 2,000 of those cases, over 2,000 of those cases per year. Our average time to resolving those cases is about 113 days, with some taking a bit longer, because when questions come up, we are committed to getting feedback from experts in a particular field to help us to fairly adjudicate cases. That gives you a sense of how that process works behind the scene. Now, it's important to help the audience understand some of the boundaries about what the board can and can't do. I've mentioned that filing that complaint is an opportunity to hold a licensee accountable if their conduct or their medical care is below an acceptable standard. Filing a complaint helps to protect others from similar conduct or care in the future. It can serve that purpose, and it's an important purpose. But what it cannot do is necessarily resolve all of the problems that might come up between yourself and your physician or PA. We cannot necessarily intervene to resolve all situations. I'll give you an example. And the reason that I I clarify that just to manage or not to convey the wrong idea. So yes, if for instance we have often a problem with death certificates being signed, or someone unable to access a record, it's being withheld by a clinician for some reason or the other, because it falls squarely within our workflow, our interactions and reaching out with that clinician oftentimes leads to the resolution of a problem. A death certificate is signed, medical records are released. But there are times when the public reaches in and saying, we need you to get this doctor to change this medication. That's simply something the board cannot and does not do. But if your concern is the medication was prescribed at a wrong dose and it has caused harm, yes, that's where we become more engaged in the process. So I hope that helps. We encourage that we cannot influence a medical doctor to change how he or her is managing their practice or their care. That's not our primary role. We're often approached around the question of lawsuits and whether we can facilitate that process. That's simply not what the board does. Oftentimes, in addition to telling us a narrative about something that was not done well, there is a request, sometimes a demand, that the medical board facilitate reimbursements or compensation for care. An apology from the clinician. Those are things that we simply can't, we're not authorized and not in a position to adjudicate or manage. And it's important to remember that so that you're setting the right expectations when you're going into the process. I think you'll have that opportunity to have that clarified when you log on site to file a complaint, but it's important to get that understanding and appreciation to the audience. And this is sort of, this is a reiteration, and I'll go into actually each of the bullets because I think there are some fine points that they're worthy of highlighting. Do file a complaint if the medical care that you received is a thing that you felt just was not hitting the mark. You feel it just did not hit the standard. I've gotten care elsewhere. This particular medication was not provided. It could have solved my problem and kept me from having to go on to an emergency room or have a, let's say, a surgical procedure as a, for instance. You're really very concerned. You've had a chance maybe to communicate with the clinician. You've not had an answer, the licensee or the board, but you've not gotten satisfactory answers, or you're simply not comfortable confronting that. Consider filing a complaint. You believe the conduct is unethical or unprofessional, and we have some examples cited here. It's important. Let us know. We want to be able to exercise the authority the board has around in this area to facilitate, to explore, to help answer questions if we can. And this last point I think is important. It's an altruistic point. It's a community-based point. Taking the time to pause and bringing care concerns to the attention of the board does help your fellow man in the sense that if there is something there that really ought to change, really needs to improve, it's a service to the community. So what is involved? Now, you say, okay, I am ready to do this. I have a situation. How do I get this done? Well, it starts off with taking a look at the online tutorial. It's not a complex process. And the disadvantage yes, it's easiest when you have access to connectivity and a computer or your cell phone. But you can start that process by taking a peek at the tutorial that's available on the site. Gather your information together. And then provide the demographic, the logistics, the information that's important. And in a clear and concise way, it helps. Sometimes we have complaints that are multiple pages that are filled with side narratives that actually have no immediate relevance to the office visit that you may have had. try to keep it focused on the main thing, that event, that process that you were a part of. So keeping it clear and crisp is helpful to sort out the details. And gather any of the information that you need to have, any documentation that you might have in, and submit that on the application, on the online form. We have here screenshots that help you to visually to sort of observe what the site looks like. And oops, did not mean to do that. Here you have the file a complaint tab that you can move right into. We're moving on to that second screen, a complaint, filing a complaint from patients and the public. And a third screen, and walking you through. Okay. This particular slide walks you through some of the details of the components of what happens behind the scenes. And you may have asked the question, why on earth does it take 113 days to resolve a case or longer? I think it's important to note that the fairness of the process is embedded in the many hands that have an opportunity to review, to consider, to examine, and to bring years of expertise to the situation, as well as other experts in the field to provide some insights. So the complaint that's filed, the information's received, an investigation is conducted. Our significance, our very well trained staff will review and make the recommendation that we then submit to the full board. Now, remembering, and I don't think I mentioned this, that the faces that you saw on the screen earlier in the presentation are working people. These are clinicians who are, we have public members, we have PAs and a nurse practitioner, and we have clinicians, DOs and MDs. They are working, they are actively about their lives and their days, in their practices and various work environments, and it is our responsibility to do that initial work and investigation. Then as the board meets once every 2 months, they review these cases and then either endorse the recommendations that we have made as the staff to the board, or they use their expertise as frontline practitioners and public members to help us refine those responses. There's a deliberation, there's a vote, and then there's a case resolution. And that involves notification of both you, the person who filed that complaint, and the clinician who might be involved. I hope that's clear. And amongst the possible outcomes that can happen, this is a statistic that helps you, it should help you to feel completely comfortable with the idea that the majority of the clinicians in the state are practicing according to an acceptable standard. There are private actions, which is we found some elements of care that could do some tuning up. And then there are public actions, i.e. things were really out of line to the point where we felt licensees or the community needed to know, hey, we need you to know about what's going on with this clinician. There was an event that the public should know about. Other ways that we are supportive of the licensing and regulation process here in North Carolina, we maintain a comprehensive base that allows you to look into the portfolio of a particular clinician. So if you have an interest of visiting or checking in on your own clinician, you can log on to our website, and there was a tab that we looked at earlier that allows you to and we'll look at it going down into the other slide deck. Examine your clinician, find out the licensee or physician that you're going to see, or PA, to get a snapshot of their training, their certifications, and whether or not there has been any regulatory actions taken against them in the past, to include criminal convictions, hospital actions, and so forth. Malpractice cases are also cited there for a period, I think, of 7 years. And that tab, which is next door to your file complaint, you move right on over here and you're looking up a doctor or PA. Once you do that, you come up to the demographic page where you enter the information, some basic, you don't have to fill every field. It takes you on then to provide you some information about practice information, education, certification, and all the other information available there. I think I'm moving a little slow on time, so I'm going to pick up the pace just to get us through. So you can get that information there. And then we have our telemedicine overview. We thought it would be helpful to just briefly touch in on what's happening in telemedicine with the pandemic. I'm sure all of us, or most of us who have been trying to seek care in the past year or so, have had some form of interaction with telemedicine. It is the practice of medicine, but it uses primarily an electronic or device for communication, whether that be simply a telephone or synchronous video, audio platforms. It allows your interaction with your provider in a such situation where you are in your comfort zone, and it is in a substitute for your inpatient visit. It has improved access to healthcare during these times, and it also helps us out in areas where traditionally and historically rural communities have had some struggles. There is a sense that it increases the efficiency of healthcare encounters, although most recently some data might imply that there are some inefficiencies that might come out on the doctor's side, the licensee side of it. But overall, there is a high level of satisfaction by the public for having this available. And it is helpful for illnesses that are like a cough or a cold, or something that's a bit longer, like diabetes or long-term medication management. They're easier to fit into your schedule. And finally, insurance companies are actually compensating. So there's incentive to hold on to these models moving forward. And certainly there are many more options for viewing after hours. And then, of course, I think all of us can relate to perhaps being so ill or being uncomfortably ill, and you'd rather not sit in a waiting room. Let's say you have a suspected case of maybe a flu that might not necessarily require no shortness of breath, no things that are big, but can be managed by. And it's important to land on that and to state that it's not realistic to expect that if you're having shortness of breath that you should use a telemedicine visit for that. You're uncomfortable, you're feeling like this is something you'd like to get some advice on, but it's not the sort of thing that, might require a throat swab or medication, immediate medication and administration like a shot, strep throat. Those may be challenges for telemedicine at this point, at least. So we are expecting that the standard of care that you receive overall is commensurate with what you would receive in a face-to-face visit, gathering of the appropriate information, who you are, your list of medications, and so on. And then an appropriate evaluation that might involve you helping out in some aspects of the exam. And just remembering that not all complaints are amenable to a remote diagnosis. So don't be surprised if in some situations you're asked to come in. Some important tips: try to think of your visit not as a global big, but small specific areas. Taking notes in advance, setting up a quiet and appropriate place, knowing your pharmacy details, and have details the doctor will need from your medical history that might be important in case this is a provider that you're seeing that's not someone who knows you and knows your history. Red flags include an absence of an effort to confirm your identity. That is a problem. Someone who does not share their credentials, who they are. Offering a prescription without an appropriate evaluation. Insisting on using a specific pharmacy. These are subtle flags that I think most people would probably pick up on, but it's worth mentioning here. And offering any services that are unrelated to your visit. You want to think twice about who this provider might be. And I pause here, one, because that's the extent of our slide deck, but at the same token, it does provide us a few moments for one to share the information about whom you might want to contact on our communications team, the website address. We have a presence on Facebook and Twitter, and it would be wonderful for for me to be able to answer any questions that you might have. And thank you for the chance to share this basic information.
Thank you so much. That was incredibly helpful. I think especially, just pointing out where to go on the website and the different things that, you might not be able to help folks deal with. I guess, I have a couple questions. Um, I'm wondering if there's cases where you've gotten where there's people that have maybe said, okay, I'm not really sure if this is a complaint, if this is something that you all can help with, if it's kind of like a maybe more subtle thing.
Yes.
Yeah, if you have maybe an example of that.
Well, I'm interpreting your question in two ways. If you, for instance, Corey, are thinking, well, is this something that elevates the level of talking to the board about? We don't indiscriminately accept all complaints. So if you're uncertain, gather your information together and submit it. And if it is something that our screeners in our complaints area feel, this doesn't quite fit in our wheelhouse, it maybe belongs to the Department of Insurance, or it's an OSHA issue or another area. Our sister board, for instance, it's a nurse practitioner and it's best adjudicated through the nursing board. We'll support you in helping to make that decision, because
That,
sometimes you just don't know.
yeah, absolutely. Yeah, I agree. And that's really great. I think that, that would help people feel a little bit less anxious with things that they're not really sure of, and just kind of helping get some guidance. I think that's great.
That's a great question, Corey. And I would just invite that don't let that stop. I mean, clearly we ask you to pause and process, because some of the nature of the complaints that we see, you think, I don't know. They're just sort of an emotional, angry situation. I want to be compensated, or things of that nature. But if you've thought it out and you're still having some lingering doubts, send it in. It cannot hurt. We have had quite legitimate cases be presented 4 years. I just recently reviewed a case. It was 4 years after care. And it turned out that this was something that that person had been really kind of mulling over. And it turned out to be something that was worthy of our attention. So,
Oh, yeah. Yeah. I can imagine, addressing it sooner and
would be good.
would be,
Yes.
yes.
That was the point. Thank you. Yes.
Yeah. Can you speak to, maybe any situations that you had where, people faced like some very blatant discrimination with healthcare providers, and how you've been able to kind of help through that process?
We fortunately, as far as we're able to identify, so sensitivity and the bar for this is being developed even more in light of the seasons that we're in. We don't receive clearly identified cases like that very often, but in some cases we do. And in some scenarios, because of documentation issues that boil down to narratives of he said, she said, we are not necessarily able, once our investigators have done their work, able to determine the greater evidence of the truth around the interaction. I will say this, it's still worth submitting the complaint, and let me tell you why. Remember that component of the slide where I mentioned that part of submitting a well thought out complaint is about the service that it provides to the community? Well, Corey, I think the good news on a situation that might come up where we're not able to really come down and say, hey, it's very clear that something happened here, the record of it is retained. And so if we see another and a third, well, we move into a different space, because we have then the evidence of time, the tincture of time, we call it, and repeated complaints to help us know what to do. So I would encourage, I I would encourage engaging the system. And I guess I'm anticipating, because of the nature of some of the complaints, we cannot always give the satisfaction that a complainant, that's who you become, the public, but it serves a purpose and you're building a foundation. So please consider it.
Absolutely. Yeah. Well, that's really good to hear. It's great. Um, yeah, I mean, I particularly asked that because I think a lot of people in the LGBTQ community, especially transgender individuals, deal with very, obvious, blatant discrimination, sometimes maybe not as obvious, and, some really tricky situations of being in the
Yes.
community and,
Yes.
dealing with providers that, just not supportive. There's a lot of providers that don't necessarily have the tools and the education to work with LGBTQ clients, but there are definitely times where I've seen like some pretty horrible things, in the community, and so that's really good to hear, especially since as you said, things are changing, and
Yes.
so that's great.
Well, professionalism is a part of giving great care, and it's important. So do share, and we
Mm,
will use the tools that we have to do the best job that we can, given what we have.
right.
I'm so
Great.
glad you brought that out. Yes.
Great. Yeah. Um, Well, I left a note for anybody in Facebook land that wants to ask a question. I don't see anything popping up, but we've had people tuning in. So I'm
Fantastic.
I'm I'm hopeful that this has been some enlightening and important information for folks that are listening, that will be hopefully helpful for anybody who's just didn't know about any of this. I mean, I certainly didn't know about
Yes.
it much until you all reached out and we started having conversations. So this is great. This is really great information.
Fantastic. And I just encourage those in the audience who are still with us and listening to, pass it on, share that information, share what you've learned today. Thank you, though, for the chance to speak with you. It's been a
Absolutely.
pleasure.
Yes, thank you. All right, well, I'm
Okay.
gonna